Welcome to Physician Focus. I'm Dr. Bruce Carlin. Colorectal cancer is the second leading cause of cancer-related death for men and women in the United States. The American Cancer Society estimates that more than 134,000 cases will be diagnosed this year, with more than 50,000 deaths. And while the risk of the disease increases after age 50, physicians are beginning to see more young people, some as young as in their 20s, getting the disease. In this edition of Physician Focus, we'll discuss colorectal cancer, screening techniques for the condition, and how you can dramatically reduce your risk for the disease. Joining me for this discussion are two board-certified gastroenterologists, Dr. Francis McMillan Jr. and Dr. Raj Devarajan. Dr. McMillan is the owner and president of Merrimack Valley Gastroenterology, a private medical practice in Haverhill, Mass. He is a founding member of the Massachusetts Gastroenterology Association and currently serves as its president. Dr. Devarajan is president of Middlesex Gastroenterology and Endoscopy Center in Acton. He has served as chief of gastroenterology at Emerson Hospital in Concord and Neshoba Valley Medical Center in Ayer, and currently is the president of the medical staff at Emerson Hospital. He is a member of the board of directors of the Massachusetts Gastroenterology Association. Welcome.
Thank you.
Thank you. Pleasure.
Nice to have you. So let's start with a simple question. What is gastroenterology? Raj, you want to take that?
It's a field in medicine. It's a field of study in medicine, much like you might have cardiology or neurology. Gastroenterology really deals with our entire gastrointestinal tract, and people might think there's many parts, and there are. You start with the mouth, go down the esophagus, and go down into the stomach, and the small intestine. It's called small because it is a small caliber, but it's actually the longest part of it. It's about 30 feet, and then you go into the large intestine, which is also called the colon. And there are other organs that we take care of, the liver, the gallbladder, the pancreas, but today I think we're discussing mostly the large intestine, or the colon.
So what functions does it play, and what are you responsible for managing when those functions go wrong?
Well, particularly with regard to the colon is basically the repository of stuff that we can't use. When you eat a meal, it goes through your swallowing tube, your esophagus, into your stomach. The small intestine does all the work, but we can't digest everything that we eat. And so there has to be a place for it to go. And the large intestine or the colon is the place where that happens. And there's an interplay between the bacteria that live in the large intestine and some of the diseases that go on there. And so that's a big part of what we do, because it turns out to be a place where lots of problems happen.
There are problems in gastroenterology. There are issues in the esophagus, the stomach. There are very many issues, both in all kinds of diseases, either infection or cancers, inflammatory diseases of the intestines, and cancer of the colon weighs very heavily because it is such a serious cause for morbidity and mortality.
So you're dealing with a whole bunch of other parts of the gastrointestinal tract, and we're going to focus tonight on the colon. So how prevalent is colon cancer?
Colon cancer is the second leading cause of death in this country and in many westernized nations, and that might tell us something about why it occurs, but it is the sad part is it's very preventable. And
average American vastly underestimates their risk for colon cancer. The risk of colon cancer, the lifetime risk, is about 1 in 18. That's by age 80. If you do not get screened, that is the likelihood that you're going to get cancer. So that means that most people in this audience are going to know somebody, and they're going to be close to somebody who gets colorectal cancer. And the idea of screening is to dramatically reduce that number to something quite a bit smaller. The other part of it is that Dr. Devarajan and I take care of all sorts of gastrointestinal disorders, things like esophagus cancer, stomach cancer, pancreas cancer. We take care of the whole gut tube from one end to the other. But if you think about where the disease is, the vast majority of the disease is going to be in the colon and rectum. Colorectal cancer is by far much more prevalent than cancers of anywhere else in the gastrointestinal tract. People are surprised to find that out.
Yes, they are. I mean, esophageal cancer has actually been told to be on the rise because of reflux. But even with that, and even with colorectal cancer somewhat declining with our screening and preventive techniques, colorectal cancer is still the #1 cancer in the gastrointestinal tract.
Well, why does colorectal cancer happen? What are the theories as to its cause?
That's a great question. I think it's an interplay of genetics, environment, diet, lifestyle. There are certain things, toxins that we put in our body, like cigarette smoking, contributes to colorectal cancer. A lot of people don't make that association.
There are some things like smoking and alcohol and high red meat intake. But what's really interesting, Bruce, is that it's such a high prevalence of colorectal cancer in westernized nations. And you take countries in Asia where the incidence is quite low. And it's interesting in that if they immigrate to this country, after 10 to 12 years, their incidence is the same as Caucasian Americans or Americans who grew up here. So there's a lot of environmental factors, I think, that we're yet to identify. But so far, we have identified it to be, if it's high fat, low fiber, more processed foods, these seem to have a link.
So the things that we don't, when we don't allow ourselves to concentrate quite as many toxins in our colon, we do better. So the fiber works better by
Yes.
diluting. Is it theories to that?
We are not entirely sure how fiber works better, but it does give better function to the colon. And even in people who are not at risk for colon cancer, fiber seems to help their colonic function. So sometimes we use even synthetic fiber, but dietary fiber is definitely helpful.
And the fiber part, I think the answer is probably going to come from the interaction with the microorganisms that live in the colon, because the types of foods that you eat actually select the type of organisms that live within you. Some of them are helpful and some of them are not. And I think there's more to be said on that topic that we just don't know.
A lot of research on what our microflora is in the gut, and
there's a tremendous amount of research now. There's a whole science to it about the organisms that sort of coexist with us. Some are good and some are not so good. And when the not so good ones outweigh the good ones, that's when disease occurs.
So how do we screen? What are the guidelines? What should we be doing? What's the word? You both are very active in the gastroenterology societies, so tell me.
I'll tell you what I had.
Okay.
I turned 50 last year and I had my colonoscopy. I did that because I know it's the best test out there. I know it's the test that is most likely to find something that could cause me harm. And I know it's the only test that actually reduces my personal risk, not the population risk, my personal risk of having a colon cancer. I don't want to have a colon cancer because I know the devastation that it brings. And that was a gift that I gave to myself last year.
Unfortunately, it's closer to me. I have family history, and so I actually had it screened earlier than 50, which is what we advise. We advise screening at age 40 if there is a first-degree family member with colon cancer or significant polyps, or 5 years before the first cancer in the family, whichever comes first. So I actually had it at 45, and luckily I did have some polyps and they were removed. And I think the real key, Bruce, is that this is not just screening, this is a preventive test. If you could show the polyps occur, and this is what it generally looks like.
It's blown up a bit.
It is magnified, yes. But it can either be polypoid or pedunculated or like a mushroom, or it can be flat.
Pedunculated means it's on the stalk.
Yeah, it's
Okay.
like a mushroom, or it can be very flat. And these are, a lot of people come around saying, oh, it's nothing, I just had polyps. Well, polyps are the key, because
That's what
we
we're
want to
looking to-
remove the polyps, because they're the ones, even though they're benign, they're the ones that eventually, can go to cancer. And as you can see in this surgical specimen of the colon, this is a polyp here, and then over time.
So just explain what we're looking at.
So we're
here.
looking at the colon, which is a large
Somebody's filleted
intestine.
colon for us.
Yes, it's a surgical specimen, meaning they've had cancer, so they've had to have their part of the colon removed, and the surgeon has opened up the colon to show where the growths are. And this is a good example, because at one stage you may have had just this, which is a polyp.
A polyp.
That's a benign
and that's
lesion.
what we were looking at in the last slide, essentially. It looks like it could be pedunculated.
Exactly. It's a benign lesion, but we want to remove these because without this, this will grow into this, which is now a cancer. And then it's much more difficult.
And just showing what the cancer is, that's invading the tissue
It
as
invades,
opposed to the polyp,
right.
which is
You're
sitting on top, more or less.
exactly right. And when we know when there's invasion, the tissue has blood vessels. When there's blood vessels, then the cancer cells can travel to other parts of the body, and that is where you have a higher stage of colon cancer once the cancer spreads. So we really want to remove it here, so that you don't actually get cancer. So I think the real take home is that this is not just screening, but we're actually preventing colon cancer.
So it's unlike your other tests.
You would ask the question, what are the other tests that you can do? The other tests are more on the screening realm as opposed to the prevention realm. The nice thing about colonoscopy is, although it is invasive, it's a day out of work and things of that nature, it really takes both steps. It's not only is there disease present, but it fixes the disease that's there. The other tests are not so bad at picking up the disease. There is a new test that was approved, I believe in 2014, called Cologuard. And that's the one that is FDA approved. It is a DNA test that tests for abnormal DNA that they have determined is present in a large number of cancers. And so what Cologuard does is it's very good at picking up cancers, but it's not so good at picking up benign polyps, which are precancers. And so if you do get a Cologuard test and you have a cancer, well, there's a good chance that you'll pick it up. But I think both Raj and myself would both agree you want to get these things far before that. The likelihood of Cologuard picking up your cancer is about 96%. But it's only about 40% sensitive for advanced polyps. Those are the polyps most likely to change to colon cancer.
So you're picking it up and treating the polyp, you're actually preventing the Cologuard from turning positive.
Well, that's one way to look at it.
Something like that. Yeah. And this has been shown over the last several decades. And it's all about awareness, Bruce. When people are aware and they know the importance, they go get screened. And when they get screened, colon cancer incidence actually drops. This has been shown in the colon cancer rates in this country. The first dip that we had in colon cancer incidence occurred after Ronald Reagan had a polyp. People went, learned about it, got screened, and if you notice 5 years later, the incidence actually dropped. The next smaller dip occurred with Darryl Strawberry, and the biggest dip, of course, with Katie Couric, who has really made it a mission, and we're very thankful.
We're not going to do that on this show tonight. That's just
Bruce?
No, thank you. But the paradigm that we use in a lot of cancer is that there's a precancerous lesion that goes to a cancerous lesion, and this is the one place where we know where it really works. It may not be, that paradigm may not be as true in other areas, but here, we've got ample evidence that the polyps do go on to cancers, and your screening technique really does harvest them.
There are some people who either can't have a colonoscopy or won't have a colonoscopy because of maybe a personal preference or things like that. There are other things that you can do as well. Doing a simple annual test at your primary care doctor's, having a stool specimen checked for hidden blood. This is called occult blood or hidden blood. It can be done by various methods. One is a chemical test called guaiac. Another one is called immunochemistry or FIT, fecal immunotesting. These tests are good at picking up blood. What they lead to is generally a colonoscopy. They identify somebody who will get the most benefit from getting a colonoscopy. It's been my experience that people who get referred to my office who never quite pull the trigger and get it scheduled, they may get one of those fit tests at their primary care doctor, and then they're on my schedule next year, and they're very happy they've had it done.
My concern as a primary is that you do a fit test for 5 years running, and you never get your patient to bite the bullet and get what they need done.
I think 5 fit tests over 5 years has a pretty good negative predictive value. I'd turn that over to my colleague.
I think it is right. And again, that says that there's no blood, and we can believe it after 5 times. However, as Frank correctly pointed out, blood is not what we want to wait for. We want to wait for the polyp that does not bleed, because once you see blood, it could be an advanced lesion, and we want to get it at the early lesion.
Yeah, advanced basically means large size or tissue characteristics under the microscope that look close to a cancer. And so we're looking for something called villous tissue, or we're looking size greater than 10 millimeters. That's the threshold of what an advanced polyp is. You don't want to have an advanced polyp, and if you do, you want it out, because those are the ones that have a high risk of changing in the near future.
So let's delve into that. How often should you get the colonoscopy? And my patient's issue often is, well, I had a little something in there, I don't know what it was. And then you guys come up and say, oh, well, that was a villous adenoma, or that was, and they say, well, what's that? Can you explain some of the items that go into how frequently we test?
Well, not all polyps are equal. What we're looking for is something called an adenoma. And an adenoma is a fancy word that basically means gland. And these are growths or tumors, if you will. They're not malignant, but they're benign, not cancer. But when you have a growth of the glandular component, that cell predicts that it could be transforming into a cancer down the road. So if you have a non-adenomatous polyp, a polyp that does not contain that glandular tissue, those polyps in most circumstances we will ignore, and there are some subtle nuances with that. But the adenoma really matters. If you have 1 or 2, we're calling you back in 5 years. If you have 3 or more, it's 3 years. If you have 10 or more, it's a year or more frequently.
There are very clear guidelines set by all the agencies as to how often people should be screened. I think the real confusion, Bruce, is that people don't know really what they had. They call it different names in lay terms. They call it, oh, it was nothing but it was just a polyp. And that doesn't tell us a lot as to whether, as Frank said, was it big? I always tell my patients that size matters, over 10 millimeters. Is it flat? And is it villous? And if we can ascertain that, we'll be able to better tell as to what their risk is. Because 30% of the American population do have polyps. Only 6 to 7% go to cancer. So not all polyps go to cancer. So we do have, and that's where the confusion occurs. You may come for a colonoscopy and we may say, well, come back in 10 years because you had nothing. Or you may have 1 large polyp and 2 large polyps, and we may say come back in 3 years. So there's different timelines depending on these 3 factors as to when you should have it.
And those timelines depend on a good to excellent prep quality. So they presume that you've had a very good prep. They presume that the doctor got all the way to the top, that they documented that they got all the way to the top. So just like Raj just said, when I get somebody who tells me they have polyps and I go pull the operative report and they had hemorrhoids, well, that's not the same. So,
but if they didn't get past the hemorrhoids, you'd want to know about that too.
So I always look to see that the exam was complete, that they commented that the prep quality was good or excellent, and if that's the case, then we're following the guidelines. If it's not, guidelines are guidelines. We can go outside of them. I think that if you're going to go outside of a guideline, you need to have a justification for doing so. But we can go outside the guidelines, and there may be times when the doctor does. So what I say tonight may not apply to your individual situation. You really should talk to your own qualified gastroenterologist and make sure that you understand exactly why they went outside.
My patients complain, well, I heard that prep is terrible. Now, I've had it, and you spend the night on the toilet, but other than that, it wasn't all that bad. What can we do to quiet the fears about the preparation, or are there things that you can do to modify the preparation so that the patient doesn't have to go quite as aggressively.
You know, there's
Raj?
no, unfortunately, there's no free lunch. You want to clean 6 feet of bowel, you have to give a prep to clean that out. And the Times had an article even 20 years ago saying, well, the importance of the colonoscopy, good colonoscopy is the prep and the endoscopy skills. So prep is important. What I tell my patients is, if you were able to really evacuate the colon well in the 5 preceding days, you may not need the whole prep. I tell them, do the prep. I know it's bad, I know it's large, but if you start to come out clear, you're done. You can stop. So they don't have to do the whole prep if things are going well. So unfortunately,
That's not a big message that we want here. If you're going to do the 5 days to get it clear, you're going to be on clear liquids for part of that, and trying to...
Low residue, yes.
Yeah, very low residue.
There have been some improvements in prep techniques, and probably the best one in the last 7 or 8 years is we now split all of our preps. We don't give them all at once. We'll give one maybe in the afternoon, one late in the evening. It might interfere with your sleep on the night that you're going to be having, the night prior to your procedure. But that's a day that you're not going to have anything to do about. You don't have to be on your A game. All you have to do is present yourself and fall asleep. We'll take care of the rest. But splitting the dose has made the preps a lot more tolerable and gotten us really above that 90% good to excellent. And so there's lots of different things that we have. If what you had the last time didn't work, we can offer you something different. I've personally tried 2 or 3 of them. They all work. I haven't found them terribly onerous. I find that chilling them and drinking them with a straw hits the back of your tongue so you don't taste it so much. And then also not taking it all at once kind of reduces the bloat, sometimes the unpleasant symptoms that go along with it, just dividing it. And sometimes we'll have people do the second one early in the morning, 3 or 4 hours beforehand.
At the end of the day, I say you may suffer, but it's saving life once in 10 years. You know, let's get it done.
If you're going to do it once in 10 years, you better have a good quality.
Yeah, you don't want to go back.
Exactly.
You know, if you have a half a prep and not do it. I think that's my patient's biggest obstacle to getting the test. What other obstacles do you see, and what can we do to overcome them?
Unfortunately, financial obstacles are becoming the problem du jour. What I have seen is that high deductible plans are multiplying. These high deductible plans are applying to people who don't have health savings accounts. These people are middle class people. They just don't happen to have a lot of extra money around, and it's become a big lift for many people, and it's really competing with, you know, whether it's a mortgage payment or putting food on the table, or, you know, paying your kids' tuition for college. I mean, it's one of many things. It shouldn't be a discretionary expense because it's really it's your life, but it unfortunately has become that, and I've noticed that over the last 1 to 2 years particularly.
I do think more can be done in that regard, and as you know, we sit on the Massachusetts Gastroenterology Association board, and we're trying to educate both insurers and people that this is important, and hopefully it'll be less onerous when patients get it.
A couple of other issues. Believe it or not, we're getting close to the end here, but I'd like to hit on one more topic. You said at the beginning that there were more young people being diagnosed with colon cancer. What's happening there? Frank, or Raj?
I think we're doing more testing.
But how do we pick up, you know?
So I think
the
there are
question
two.
is the incidence increasing? And
Yeah.
I don't know that I know the answer to that.
There are 2 parts. I think Frank is right. We are doing more testing, and I do think that some of these things we alluded to earlier about environmental factors, diet, etc., are going to come into play, so that the younger population who perhaps has a different diet and environment since, say, when we were growing up, Bruce, you know, and I think that they may have more risk factors that we're yet to learn about. But
That
we're
we don't know
definitely
about,
we're
yeah.
definitely seeing younger patients.
Unfortunately, I think that that's right. The genetics don't change. We all have the same genes that our grandparents did, but our lifestyles change, our diets change, the way we get to adulthood changes.
Well, I'd like to ask, are there some important take-home points you think that we should leave with our audience? I'll start with you, Raj.
I think that I'd just like to reiterate, this is not just screening. we are actually preventing cancer. And this cannot be said for many or even a few cancers. Most are screening, and this is actually preventing. And if we can prevent a major cancer killer, then we should go ahead and do it. And it's easier than we think. And so I would encourage everybody to follow the guidelines, see their doctors, get their colonoscopies, get the FIT test, whatever it takes. And so that's my message.
I didn't ask you specifically earlier about that, but what are the figures if you get screened versus not getting screened? Do we have those figures as to how much of a difference that is?
For colon cancer?
For colon cancer.
So that is a study that will never be performed unless it's retrospective, because you cannot deny colonoscopy to a population for a study.
Yeah.
But we do know that the population, certain towns, certain communities that have a higher rate of screening, their incidence of colon cancer is lower.
Frank, do you have parting words for us?
Well, I always like to say that people, when they think about their health care, what are they really looking for? And they're looking to live well and prevent disease. And the thing that a lot of people are afraid of getting is cancer. And so my stock line is that the number one cause of cancer death in the United States is lung cancer. The number two cause is colon cancer. So if you want to dramatically reduce your chances of having cancer-related death, don't smoke, get a colonoscopy, and I think you'll be pretty well on your way.
Well, this has been a wonderful discussion. The two of you are excellent guests, and I want to thank you for joining us on Physician Focus.
It's our pleasure. Thank you for bringing this to the forefront, because this is important.
Thank you for giving us the opportunity to talk to your public.
Thank you. For more information on colorectal cancer and screening techniques, visit our homepage at physicianfocus.org. I'm Dr. Bruce Carlin. Thank you for watching.
I'm Dr. Frank McMillan.
And I'm Dr. Raj Devarajan.
Colorectal cancer is the second leading cause of cancer-related death in the United States, claiming more than 50,000 lives each year.
The cancer occurs in the colon and rectum, parts of the large intestine, and is caused by growths called polyps that can turn into cancer.
Screening for colorectal cancer saves lives, but 23 million American adults, about 1 in 3, don't get screened as recommended.
Colorectal cancer affects men and women, and the risk rises with age and a family history of the disease. If you're over 50 or have a family history of the disease, early screening is recommended.
Screening can reduce the risk of colorectal cancer by up to 90% by finding and removing the growths before they turn into cancer.
For more information on colorectal cancer and the different screening tests available, visit the American College of Gastroenterology.
I'm Dr. Dennis Dimitri.
I'm Dr. Monica Burrell.
Prescription drugs are valuable medicines, and when taken under a doctor's supervision, provide effective pain relief for many conditions.
But the abuse of these powerful drugs has become a serious public health problem in Massachusetts and across the country, resulting in the needless deaths of thousands of people.
If you are prescribed opioids or pain medication, talk with your doctor about the risks and benefits of the medicines and explore different ways to treat your pain.
The safe use of prescription drugs comes when physicians and patients work together to promote healing and good health.
Medicines cure, heal, and relieve pain. Use them carefully, store them securely, and dispose of them properly when no longer needed.
What you do can make a difference. For more information, visit the websites of the Massachusetts Department of Public Health or the Massachusetts Medical Society.